we'll just start with talking a little bit about PCOS, talking about the definition, a little bit of pathophysiology, how it works, how it's diagnosed, and treatments. And feel free to send us questions, and we're happy to answer that during and after also. So I'll start with defining PCOS. So PCOS is one of the most common endocrine disorders in reproductive age women. And a common misconception is that PCOS is a specific disease entity that is causing issues of ovulation or anovulation. And the actual fact is that PCOS is basically the consequence of a chronic anovulatory state. And so there are actually many different causes for women not ovulating, but ultimately they all, if a woman's not ovulating, ultimately, that's the diagnosis of PCOS. And so it's a condition where there's multiple factors contributing, genetic, environmental factors, but it's generally characterized by an increase in insulin levels, an increase in androgen levels, and obesity can also kind of aggravate this condition. And so I often will describe to patients that in a normal menstrual cycle, there are certain hormonal changes that happen. So it starts with the brain communicating with the ovary, saying it's ready to start a cycle. So the brain produces FSH, and that will go travel to the ovary and tell the ovary to produce a follicle. The ovary will then grow a follicle. It's making estrogen. A certain level of estrogen is released, and that will go back into the brain. Okay, it's time to ovulate. And then there's a release of LH, which is the LH surge, and that's what you're looking for when you're doing ovulation predictor kits, is that LH surge. And so that's kind of how the process of ovulation happens. So in PCOS patients, there's, I describe to patients kind of a disconnect in this communication between the brain and the ovary. And instead, there's kind of these steady state hormonal levels. So instead of these kind of ups and downs that would normally happen in the cycle, there's just this, chronic steady state. And so the woman ends up, not ovulating. And so that's kind of the, how I describe it to patients. Roohi, would you add anything to that?
No, I think that's perfect. And I think I know what you started off with is really good to know that most patients, they Google PCOS and then they think, oh, well, I get my period or I don't have all of it. It really varies in presentation. And it varies in presentation, especially in South Asian females. I think it's different. And I learned that the hard way. I always knew I had PCOS because I was diagnosed very early on. But as I got older, I thought, well, those symptoms went away. Like my acne wasn't as bad as it was when I was a teenager. And my cycle started regulating. And then you go on Dr. Google and you're like, oh, that's just from being a teenager. And I was like, oh, I was misdiagnosed. It wasn't PCOS. And then they got older because they started becoming regular for me and not cystic acne. And just in general, I was like, well, I'm hairy, but I'm Indian, like what Indian's not hairy? So I was like, I don't have PCOS, but I think the presentation really does vary by ethnicity. And Anu and I were discussing a paper that was there that looked at the variations between ethnicity of presentation for PCOS. And I think in general, they talk about Asians. They put Asians and South Asians in one category. But even in that, if you differentiate it, South Asians don't really present with the whole picture, right? We're in general, we're very small framed, most of us. So we don't have that huge metabolic syndrome. But when we initially present, we don't present with obesity and acne, and we're all hirsute in general. Most of us have hair, a lot of hair, we also have good thick hair. So, but it's different. So I always, whenever I talk to my patients, I tell them male pattern hairiness is important. So I do have male pattern hairiness, and when I look at my mom and my sister, they don't have that. So like hair on your knuckles or thicker hair on like my chin, I'll get that. And it's hard to know that being a doctor, even like looking at the variations, right? Anu, would you agree?
Yeah, it's a huge spectrum. There's kind of the more, typically PCOS patient that you think of, like the overweight or obese patient and irregular cycles, but sometimes you'll have very thin, women and also, struggling with PCOS. So it's sometimes it's hard to diagnose, and and it can be just lots of variations to it. So that kind of takes us to a little bit to how is it diagnosed. The most common diagnostic criteria is what's called Rotterdam's criteria. And you have to have 2 out of 3 of the following characteristics. So 1 is irregular cycles, essentially, the woman not ovulating. 2 is having high androgen levels. So that can be either by clinical presentation, like Roohi was describing, with the chin hair, lip hair, and these type of characteristics, the acne. And then the last thing is having what's called PCO morphology or polycystic ovarian morphology on ultrasound. And so to kind of go into a little bit more detail on these things. So what is a normal cycle? So a normal cycle is usually characterized by having by coming every 21 to 35 days. So that's what I usually tell patients is normal. And PCOS patients tend to have, generally speaking, more infrequent periods, like coming every 3 months, every 4 months, or not even having them at all, like not having periods for a year or more. And then the elevated androgens we went over, so the clinical presentation or also on blood work. So it could be elevated testosterone levels, DHEAS levos. So we'll all usually check these on PCOS patients or patients we're suspecting for PCOS. And then on ultrasound, what is PCOS morphology ovaries? So usually it's having more than 12 follicles on both ovaries, so a mean of 12 follicles, and those follicles have to be less than 10 millimeters in size. And so that's generally what we call PCO ovaries, or you'll hear that description to string of pearls on the ultrasound. So Roohi, would you add anything, I guess, to that?
No, I think that pretty much sums it. And then I always tell my patients that sometimes we often see when, especially if you don't present with any other symptoms and you're getting worked up for infertility, that's actually the most common time you get diagnosed with PCOS, and you see enlarged follicles, and then you go back, or multiple follicles, and you'll see, well, I don't really have anything else. So you might see the doctor label it PCO type appearing ovary. And I always tell my patients that when you have that there and that many follicles activated, that your body, when trying to conceive, and later will act as a PCO patient, even though you might not necessarily fit the other 2 criteria of it, meaning you may have regular cycles. And sometimes we don't realize it because up until we're trying to conceive, we're on birth control, or if we're not trying to conceive, we're on birth control. So we don't really know what our cycle is like naturally. So even if you have like a new set, even if you have those 2 criteria, meaning multifollicular enlarged ovaries, meaning a lot of eggs, and then you don't know how your cycle's like, you may not necessarily know that you have PCOS until you're actually trying, right?
So another point that to mention too is that you want to also exclude other diagnoses. Like, for example, other things can sometimes cause anovulation, potentially look like PCOS, like if there's a thyroid disorder, if the prolactin is very high, if there are other reasons for androgen excess, like other reasons for the hyperandrogenemia that the patients present with. So, so it's important to exclude other things before making that diagnosis.
Sure. So let's go to treatment, right?
Yeah.
And then we can do it in stages. How do you actually treat PCOS? And I think it's something that, not something that you eventually, it's not something that you get, it's genetic, it's multifactorial, right? There's a 20% incidence that somebody in your family has had PCOS if you have it. And it's strongly seen in patients who have a strong family predisposition to metabolic syndrome, like high cholesterol, high blood pressure, adult onset diabetes. I always tell my patients it's a way of your body protecting itself by hypersecreting a form of insulin, which acts as a growth factor and then breaks that system that Anu was talking about, the communication between the brain and the ovary. So Anu, do you want to start with treating like preconception or when you're...
Yeah. Well, I guess I usually would start off like, I think about PCOS as one of 4 categories in terms of what the patients are struggling with. So, so first is the menstrual irregularity. So sometimes patients may not be actually trying to conceive, but just have irregular cycles and needing to address that. Sometimes they're presenting because of the elevated androgen levels, so the hirsute or acne or those complaints, sometimes infertility itself, and then sometimes, well, it's also important that there are chronic health consequences associated with PCOS, and that's always something to keep in the back of our minds that we need to kind of address and treat. So yeah, so depending on what the main complaint is, we'll change how we treat it. So just starting with the menstrual irregularity part. So, so an important thing about PCOS is if they're anovulatory and they're not ovulating, their lining is not seeing progesterone, and progesterone is very important for the lining to see on a regular basis. Otherwise, what happens is the lining is just exposed to this kind of chronic kind of low level estrogen level. And what happens is that lining builds up, and ultimately the patient will be at risk for precancerous or cancerous cells or uterine cancer, essentially. So it's important to protect the lining. And so you can do that with birth control pills or cyclic progesterone. So taking progesterone once every like 1 to 2 months or something like that will help treat that concern. So, Roohi, would you add anything to that?
No, I think that's really important. I can tell you something. When I had PCOS when I was younger, and I remember the doctor telling my mom, "Oh, she has PCOS. You need to protect her lining with birth control." My mom freaked out. Saying, you know, so anybody who's on here who's listening and who has PCOS or who has kids, no, because automatically her brain went to birth control, and she was like, no, she doesn't need that. And she would not comprehend why I needed it, and it's to protect myself from endometrial cancer. So to know that even if you're not trying to conceive, you need birth control to protect yourself from progression to precancer or cancer, or at least a period. Very important.
Yeah, and so yeah, to underscore that, it's very important to have regular periods. If you're not having regular periods, it's good to see a doctor about that, whether it's gynecologist or a fertility physician. And then I guess going on to the hirsute and the way to treat that. So generally also first line treatment is birth control pills. What it does, it helps suppress the LH in the system that will help decrease that symptom. So that is a common starting place for treating that. If that doesn't work, then there are other medications called anti-androgens like spironolactone that you can also try in addition to birth control. It's important to be on some sort of contraception if you're on these anti-androgen medications, because if you were to conceive while on one of these medications, that can have adverse effects on a male fetus. So, so it's important to know that if you're on those medications.
Yeah. For sure. And you can take care of it. You can either do what Anu said, you can do more proactive measures, like they prevent new hair growth. I think that's important to remember, because I learned that as I was taking them. They don't change what you have, because I take them and get disappointed saying, oh my God, I'm still hairy. It doesn't change that. It just prevents new hair from forming. Oral medications that are anti-androgens, and obviously you can do laser. Just be cognizant that our skin pigmentation is different than Caucasian patients, so be very proactive in who you're seeking them, their experience in doing tanner skin. And also there's creams out there that can help with hirsutism, and then or traditional threading and waxing always help, right?
Yeah, absolutely. So, for sure. And then it's good if people are struggling with this to combine both, combine these cosmetic type treatments with the hormonal treatments. And that is, definitely more helpful than the hormonal things alone. And it's also, like you were mentioning, it's good to give it time to see an effect. It can take up to 6 months with the hair growth cycle. So you have to be a little patient, to see these results with these medicines. So.
I agree.
So the next point would be infertility. So that's kind of more what we usually cover. So for infertility, I think an important point to bring up here is also having irregular cycles is in and of itself a reason to, if you're trying to get pregnant, to go ahead and see a fertility specialist or see somebody about help for trying to conceive, because it's important to have regular cycles. Having regular cycles is a good sign that you're ovulating. About 95 to 97% predictive that you're ovulating. So if you're having irregular cycles, and let's say you're under the age of 35, you shouldn't have to wait a year to see somebody. You need to have regular cycles. And in terms of first-line treatments, so there have been some good studies recently, randomized controlled trials and systematic reviews that have shown that letrozole is a good first-line option, that it increased live birth rates compared to Clomid. So that's generally my first treatment option. And monofollicular development is always our goal with PCOS patients, because we're really trying to tell patients we're just trying to replace a process that isn't happening. So if you're not ovulating one follicle, we're just trying to get you to ovulate that one follicle. So really our goal is one. So yeah, those are the kind of points I go over with patients with PCO. How about you, Roohi? What other?
Yeah, definitely those. And then I think the biggest takeaway that I kind of took away from myself is when you do that, remember your chance of conception, you're bringing it back to normal, which is about 10 to 15% per cycle. It's not that you ovulate, oh, you'll get pregnant. Because I remember like, oh, if I'm missing ovulation and I do this, it's going to work. I'm going to get pregnant. And I think it's really it's eye-opening to see that, oh, well, the chance of conception is still only 10 to 15%. It's not adding anything more. So to be patient with yourself and give yourself the needed time. So typically we say 3 to 6 months before your next treatment option. And I think hindsight is right, always 2020, because I was like, oh, well, people typically try for a year before they seek fertility help. And if I'm not ovulating, I did do a whole year to where I started having negative side effects of some of the medications with Clomid, like thin lining and cyst formation. IVF is always an option too for if you failed that 3 to 6. And now I realize, kind of being further down my journey, there's a reason they put that 3 to 6 limit on, right? Because you start having the negative side effects of it, which is a whole nother battle. But IVF is in vitro fertilization, where we stimulate the eggs, take them out, fertilize them. And I think the biggest takeaway I learned, which Anu and I will cover later, was egg quality sometimes can be an issue in PCOS, especially hyperandrogenic PCOS, meaning those patients that have a high testosterone level, which I do, and I have hyperandrogenic PCOS, where my egg quality was really poor. So until I did IVF and I realized my attrition, even though I had 40 some eggs come out, and my attrition was really big, and the drop was really big, and I was only left with one healthy normal embryo, it didn't click to me why I needed IVF. So I think all of these numbers are here for a reason. And I think having been patient, when you fail those rounds, it's hard to hear you failed, now you need IVF, but it's now looking back, I see why, because egg quality is a huge factor when it does come to PCOS. Would you agree?
Yeah. Another thing that came to mind as you were going over that is also I talk to patients about when we do IUI versus IVF. With IUI, PCOS patients can be very sensitive to the medications because they have a high ovarian reserve. So I always start with a low dose and kind of, slowly build up, because we don't want patients to overstimulate and grow too many follicles, because then there's a risk of multiple pregnancies. But when we start low and build up, that can take some time. Patients can maybe not respond or be resistant. And so I tell patients, try and be patient, in the first cycle. For sure, it can take sometimes, hopefully not, but sometimes it can take a few weeks before we see a response. So treatments with IUI and timed intercourse with letrozole and Clomid can be pretty challenging, and that's why IVF is a good option when those treatments fail. It just gives us more control over getting the one embryo and putting the one embryo back in. And so, but yeah, egg quality can definitely be an issue with IVF too. So it can be a challenging condition. Let's see.
Should go to our chronic health.
Oh yeah, chronic health conditions. So so it's always important to remember with PCOS that yes, we're treating these immediate things, the infertility, the hair growth, the irregular cycles, but also being cognizant of the long-term clinical consequences that are also associated with PCOS. So PCOS patients are at risk for having diabetes. About 35% of PCOS patients will have impaired glucose tolerance, and about 10% will have diabetes. So we always screen for this condition, when we're seeing PCOS patients with a oral glucose tolerance test or a hemoglobin A1C. Cholesterol can also be an issue for these patients. They'll often have at least one abnormality in their lipid panels. So working with diet and exercise is always something that I go over with patients. And diet and exercise can kind of treat many of these conditions. Actually, it can sometimes restore ovulation. Just losing 2 to 5% of your body weight can help sometimes, not always, but can sometimes restore ovulation and also help with these chronic health conditions. And then metabolic syndrome is another health condition associated with PCOS patients, where it's basically a constellation of cardiovascular risk factors. And so these are all things to be aware of. And so some of the treatments, usually if a patient has impaired glucose tolerance or diabetes, we can start with metformin. And sometimes a statin if cholesterol is an issue. However, if we're trying to get pregnant, that's actually contraindicated. So these are some of the things that we go over with the PCOS patients when it comes to chronic health problems. How about you, Roohi? Would you add anything to that?
No, I think that's those are all really good, and those are all what we check. And I also have to add something unique, I think, to South Asians. I tease and I call it skinny fat. So I'm very physically skinny appearing, but my insides are very fat. So they're skinny fat. Like I completely have all of the PCO picture, and I think Rupa did a really good talk on it yesterday too, during her talk with intermittent fasting and her journey with PCOS. But I believe it or not, I have high triglycerides. I'm pre-diabetic, and it took me until I started actually trying to conceive. And like what Anu said, the first thing people say is like, oh, lose your 2 to 5% body fat. And it's hard because you're already like, I'm like, well, I'm 108 and a 5'8", and if I lose 2 to 5% of my body weight, I'll be under 100. And I don't, I physically don't want that. And so it was really hard for me to understand how to change my workout and still, optimize my metabolic syndrome. To be very honest, I didn't work out. I took full advantage of being genetically having that petite body frame. So I guess, that's when that nutrition aspect really played a huge role of what we're putting in, because your body, even though metabolism wise, I looked okay, but my insides definitely were not. And it showed when I did IVF, my eggs were horrendous. And if the embryologist literally said, well, if I didn't know your age, I would think they're the age of somebody in their mid to late 30s. Like and it really impacted, and it made me realize that what was going on internally and why I was struggling. So I think it's important, even though we say, oh, well, 3 to 5% is going to take me a long time, but it's so important for just overall health, because PCOS just consumes every part of you, from your pre-conception to conception, pregnancy. You're at higher risk of high blood pressure, and I had gestational diabetes. I didn't need medications, and I was fine just controlling it with my diet, but it can really get, take a big toll on every part of your body. And now I work out all the time, and I'm still, my A1C went from 6 to 5.7, which you would think of, like at 5.7 is still very high, right? It's like cusping.
Yeah. I would not have that your hemoglobin is 6.
Yeah. And that's me. Like I cut out everything. Okay. I have a weak or sweet spot for McDonald's, but besides McDonald's, I really cut out like all Indian food. And Mom gets so mad whenever I go over. She goes, "Oh my God, I have to make American food for you. You don't eat." I like literally stopped eating every rice, and just there's like a layer of oil in her food, and I literally stopped eating that to help. I don't want to get sick. I see like what our grandparents and aunts and uncles went through, and they think it's normal. Like I was having a conversation with my uncle, and he goes, "Oh yeah, everyone has that when they're old." And I was like, "No, they don't have this when you're old. Like it's not normal."
Yeah, I think that's great to hit that point, because PCOS, especially the lean PCOS patients, you know,
Yeah.
you don't really assume that they're going to have these kind of abnormal values, and how important, you know, diet and exercise are. And so, yeah, I think that's really a good point to you know, hit across. So,
yeah. And then it's also important for me and my husband were actually just talking about this morning, to have, when you have little kids, you're not as cognizant about what you're putting in there, because you just think, oh, they're little, they can have anything. But when you look at PCOS and you don't realize, like I never understood why I have it and my sister doesn't have it and my mom didn't have it, because we don't know the inheritance pattern of it, and how we just know that if you have it, that your child or somebody is at a higher likelihood of having it. And so my daughter was eating Cheats Nutella pancakes for breakfast every day. And I was like, maybe we shouldn't give her Nutella pancakes with a glass of juice every morning. And it's hard when she's 3 years old and like chocolate dripping down her face. It's cute, but it's, you know, probably not the best diet for somebody who has a higher incidence of potentially having PCOS.
yeah, that's so funny. My kids actually probably eat better than I do. I'm like,
really?
Sure. Well, I make sure like they're getting with each meal, their veggie, their fruit, you know. So, and then I'm like eating pizza.
You're so good. No, my kids live on a high carb diet. I'm trying to sneak fruits and vegetables in their juices. I'm trying to do fresh juices at home. And
yeah. I've started like making a pan of veggies, you know, just roast the weekend, and then that'll be my stock, you know, for the week for them. And I'm making like fruit salads, and just so it keeps it, you know, variety for them, you know.
I think that's important, especially as South Asians, because we tend to have that lean PCOS, and then we go to like the auntie stage, and then it gets really bad, and that lean part goes away, and then you just become jello. I'm hitting that jello stage. Yeah. I tease my mom, like, you melted somewhere from like your mid 40s. Now my daughter said that to me this morning. She goes, "You're so soft." I'm like, "Oh, don't call me soft."
It's like you hit 40 and then I don't know.
Yeah.
Everything, goes out the window.
Melts. Just melts.
Yeah. So funny.